Yeah, good afternoon, everybody. I would like to present my PhD thesis about the anterior shoulder dislocation. So I am working as a resident doctor at the Department of Orthopedics, and my vision is that in the future, shoulder dislocation will not be a long-term limiting injury for young people. So my mission is finding the best choice therapy for each patient with anterior shoulder dislocation. Because of that, I have 3 ongoing projects, and I would like to present it today, all of them. The first is investigating the safety and the efficacy of different therapies for acute anterior shoulder dislocations. It's a network meta-analysis. So shoulder dislocations are about the 50% of all joint dislocations, and 90–70% of these being an anterior one. Acute shoulder dislocations are associated with a lot of pain and numerous tissue injuries, but the problem is that the most appropriate treatment option is unclear. Maybe conservative treatment is enough, or surgery is needed, like soft tissue surgery that we called Bankart. So our aim is there are currently no international recommendation for appropriate intervention, so we would like to provide evidence on this problem. Our clinical question is simple: which therapy is the best for patients with acute anterior shoulder dislocation? And we would like to compare the immobilization in internal and in external rotation and the Bankart surgery. We have 2 main outcomes. The first is the safety, like redislocation rate, subluxation rate, and instability. And the secondary outcome is the efficacy, like return to sport and the scores. Our hypothesis is that the Bankart surgery has the highest efficacy and the lowest rates for complications in acute anterior shoulder dislocation. And the clinical implication is to help surgeons to find the best choice therapy for each patient. You can see my systematic search that I made in 3 databases in November of 2023, and my flowchart selection with ended 19 eligible full text. And I would like to present my results. The first one is the redislocation rate after more than 24 months follow-up time. On the network plot, we can see nodes, that means the interventions. The size of the nodes means how many studies we have about intervention. And the connection between the nodes means how many studies compare these interventions. You can see that we have a missing connection between the arthroscopic Bankart repair and the immobilization in external rotation. That means that we had to make some indirect comparisons. On the league table, on the right corner, we can see the direct comparisons, but I mentioned before we have indirect comparisons too, and the network pool contains both of them. So we can see that the arthroscopic Bankart repair has 0.14 times less chance for the redislocation than immobilization in external rotation, and 0.12 times less chance than immobilization in internal rotation. Immobilization in external rotation has 0.90 times less chance for the redislocation than immobilization in internal rotation. Sucra test shows that which intervention can be the best possibility, and p-score is from 0 to 1, and 1 is the best. We can see that the arthroscopic Bankart repair has the highest p-score, is almost 1, is statistically significant and clinically relevant. The second outcome is the subluxation rate with maximum 24 months follow-up time. We can see the network plot is complete. And on the league table shows that arthroscopic Bankart repair has a lower subluxation rate than immobilization in external and then internal rotation. And the external rotation, immobilization in external rotation has a lower redislocation or subluxation rate than immobilization in internal rotation. The Sucra test shows the same, that the arthroscopic Bankart repair has the highest p-score, almost 1, is statistically significant and clinically relevant. And the third outcome is the return to sport after the therapy with more than 24 months follow-up time. The p-score is clear. Arthroscopic Bankart repair can be the best choice therapy. Of course, we have strengths and limitations. The strengths that we use only randomized control trials. Our participants was age-matched, and it's a complex and a comprehensive analysis. Our limitations are the low number of participants, a few publications to include, and missing data for important variables in some studies. But our conclusion is clear. Bankart surgery has the lowest redislocation rate and therefore the highest safety after 24 months follow-up time. So we should forget the immobilization in internal rotation after the acute anterior shoulder dislocation, and we should focus on the surgery techniques like arthroscopic Bankart repair. The implication for research is that further prospective data collection is needed to evaluate the efficacy and safety of available therapies. You can see my manuscript status that I finished, and my journal selection is a British Journal of Sports Medicine. It's a D1 journal. My second project is the medium and long-term follow-up time of open Lepage surgery. It's a retrospective cohort study. And as I mentioned before, the shoulder is the most commonly dislocated joint in the human body. The recurrence rate without any intervention is really high, almost 100% in the younger populations. And after the recurrence, if we have a bone damage on the glenoid or the humeral head, the bony correction should be considered. It could be the open Lepage surgery. But this surgery has advantages and disadvantages. The advantages are fewer relapse than Bankart surgery, and less range of motion narrowing and faster rehabilitation, but it's not an anatomical reconstruction. And it's a sophisticated surgical technique, and we have some fear about the arthrosis after the surgery. So our aim is assessing the postoperative risk of Lepage surgery. And because of that, the clinical question is, what is the chance of postoperative complications after open Lepage surgery? The patient is with recurrent shoulder dislocation, and we would like to compare the open Lepage procedure with medium and long-term follow-up time. The outcomes is the range of motion, the redislocation rate, and the arthrosis with medium and long-term follow-up time. And our hypothesis is that Lepage surgery has a good efficacy and safety in a recurrent anterior shoulder dislocation. The clinical implication to help surgeons know what to expect after open Lepage surgery. During the medium follow-up time, we had 16 patients, but we lost 4. So after the long-term follow-up time, we have 12. The medium follow-up time is more than 5 years, and the long-term follow-up time is more than 10 years. The inclusion criteria were the recurrent dislocation, the bone defect in the glenoid, the heel sac lesion greater than 20%, and the exclusion criteria were the first dislocation, the rotator cuff injury, and other co-injuries. The first result is the range of motion for medium and long-term follow-up time. On the first plot, you can see that the medium-term follow-up time, the external rotation will be significantly better than the preoperative time, and it was true for the long-term follow-up time too. And the redislocation rate is really interesting, because we can see that after more than 5 years, we have only 1 instability and 0 redislocation. And after more than 10 years, we have 2 instability and 0 redislocation. If we compare with Bankart surgery with 10-year follow-up period and the same number of operations, we can see that the Bankart surgery has 7 instability and 3 redislocation, while open Lepage surgery has just 2 instability and 0 redislocation. And finally, the arthrosis. The grade 0 means that the patients don't have any arthrosis. We can see that after more than 10 years, 5 patients don't have any arthrosis. 1 patient has grade 1, and 2 patients have grade 2 arthrosis. The strength is that every surgery was made the same surgeons, the long follow-up time, and the detailed patient documentation. But the limitation, the low number of participants, patients who drop out during the follow-up time, and the different controlling doctors. But the conclusion is that open Lepage surgery can be performed safely in the case of dislocation with bone damage. It gives excellent stability and no significant arthrosis after more than 10 years follow-up time. The implication for practice is that this type of surgery may be an appropriate treatment option for shoulder dislocation with bone damage, but of course further prospective data collection is needed. And my third topic, the accuracy and consistency of 3D MRI is comparable with CD3T in assessing glenohumeral instability. It's a meta-analysis. The following recurrent shoulder dislocation, up to 90% of patients may experience a glenoid bone loss or heel sac lesion. Several imaging tests are usually used for surgical planning, like MRI for the detection of soft tissue injuries and CT for the detection of bone tissue injuries. But what if 3D MRI can do both? So our aim is the comparison of accuracy of 3D MRI and 3D CT in the assessment of bone injuries after recurrent shoulder dislocation. So our question is, what diagnostic imaging tests are needed for surgical planning? The patients is that who had recurrent shoulder dislocation. We compare the 3D CT and the CT MRI, and the outcomes are the glenoid bone loss size and percentage, the humeral head loss percentage, and the heel sac size. Our hypothesis is that 3D MRI is suitable for imaging the glenoid bone defects as well as the soft tissue injuries. And if we have true, we can shorten the preoperative diagnostic time. You can see my systematic search that I made in 3 databases. And to summary, I have 3 ongoing projects about the anterior shoulder dislocation, and we would like to find the best choice therapy for the acute and the recurrent shoulder dislocation. So thank you for your attention, and my quote is always, hope is not enough, from Peter Hegyi.
Excellent, especially that you had only 2 keywords for searching in the last slide. It's really good. So my question is, you mentioned that you found that there was no international recommendations for surgery. It's surprising. How can it be?
Because we have different schools, like Germany, in Americans, and they always have some fight that it can be true. So, for example, Americans always made just Latagé, not Bankart. First acute anterior shoulder dislocation, they made a Latagé and everything is okay. But for example, the Germans, they made a Bankart and with remplissage. So everybody used a different technique. I think that surgeons made that they good at. So because of that, we have to make some protocols that everybody can follow.
So you say that the Germans and the US people cannot agree. This is the reason.
Yeah.
In 21st century medicine. That's
yeah,
great.
so
okay.
I hope that my citation will be really high.
But you will solve this problem. Perfect. My second question is, I didn't really understand the network meta-analysis. Can you go back to the slides?
Of course. So the notes means the interventions. Okay. The size of the notes mean how many studies have about the intervention. And the connection between the notes means how study compare these 2 interventions.
Okay, so 3 studies?
Yes.
Okay. And if you go forward, please. And why did you connect these 2 notes?
It's another outcome, subluxation rate with maximum 24 months follow-up time. So the difference is that it was with more than 24 months follow-up time. Because I didn't mention, because of the time limitation, that Bankart surgery has the highest redislocation rate after more than 24 months follow-up time. So we have 2 endpoints in our manuscript with more than 24 months follow-up time because of the Bankart surgery, and with maximum 24 months follow-up time because we don't have more data with maximum 24 months follow-up time. And the subluxation rate, when we examined it, it was with maximum 24 months follow-up time. So that's the reason.
And only 1 study?
Yes.
Okay, perfect. Thank you.